these are my disclosure. So I'm going to talk about periprosthetic fracture around the knee following a total knee replacement. And few lectures have already been held, and they have, told you about most of the things. So I'll take up most the cases, and I'll to emphasize when should you do a plating or fixation and when you should do a replacement. So this is an 80-year-old lady, no medical problems, had this knee replacement 15 years ago, and this is the fracture. And as all of you would agree, that treatment of choice in this, which is gold standard, is fixation, because the fracture is displaced and the implants are stable. And according to Rohrback and Lewis classification, this is type 2, so where the recommendations are to fix it. And this is what the fixation has been done. Anybody to refute this fixation? Anybody would do differently? Is this fixation acceptable?
Yes, acceptable.
Okay. Did you say that? So that's the 3 months and 6 months. So some amount of callus is there, but it's not really good callus. Okay? 10 months later, you can see that there's callus there, but obviously the plate is broken. So was the fixation not good? Or was there any other reason? No, fixation is not so good because there is a callus. So it's not a rigid fixation.
I would have criticized it if it was a rigid fixation.
Yeah, so it was not a rigid fixation. So what went wrong then?
The metallurgy, the plate has not got the staying power.
It has not got the?
The plate does not have enough number of.
You don't need so many screws.
Or the patient has started bearing weight early?
Patient started bearing weight after 3 months. Yeah.
None of your screws have loosened up.
Yeah.
None of your screws have loosened. It's the plate which has broken. So if I have to give a fair comment, I would say your fixation was quite good. But the ability of the metallic plate to withstand the fatigue cycles that it went through was less than adequate.
So that means the fixation was not adequate.
No. Again, we are dealing with semantics now. I will define fixation as the ability to fix things. You fixed it well.
I fixed it well for probably a young person, but was it okay for this osteoporotic lady with this?
Say that. And
No, carry on.
No, somebody, yeah, what did you say?
yeah. This is failure of implant, not failure of fixation or failure of even, I would say, biology भी अभी इतनी मैं बेकार नहीं बोलूँगा क्योंकि callus is there.
Let's have some comment from trauma surgeons. Why did it fail? Why don't you tell?
Am I permitted to? Am I permitted?
उसको यार बोते.
मेरे को नहीं allowed.
नहीं हट जा.
ऐसे में मानने वाला नहीं.
रुक जा यार.
You see, Dr. Just यार कभी
Okay, sir.
हमारी भी सुन लो ऐसी बात.
Okay, sir.
So, see, adequate or inadequate, very difficult to say in retrospect, isn't so? But prospectively, if you have it examined under image and seen, does it, on stressing, open up on the medial side or no? It gives you a quite fair idea, stable or unstable.
Now it has
And
failed.
Second,
Now it is
biology.
broken.
Even biology could be, at
Yeah,
fault.
I think biology. So
Because, you dissect so much
I'll show you
around.
the slides and what the literature says.
So my question is, would he?
Going for one concept, either in an osteoporotic bone, you only span it and don't do a rigid interfragmentary fixation, or you take a concept of absolute stability and go in for another plate on the middle side. Choose one of the concepts. That is the thing.
That's right. So this is not a simple, straightforward trauma. It's a trauma in a osteoporotic lady, 80 years old, with a knee replacement, where you can't do too much of distal fixation. So why do lateral lock plates fail? and that's basically because of metaphyseal comminution, medial defect, which was not here, poor bone quality, and I think this was the main reason. Poor bone quality, osteoporosis. The fracture may have healed, it may have taken 2 years, and for that I needed a very good implant, or maybe 2 implants, or maybe nail and a plate. And that is what is said now, that for such fractures, remember, always put either, it should be a double fixation construct, either a nail plate, which is the best, or dual plate, and there are problems with both. So this was 10 months old. Now what is the opinion? What should be done now? Refixation or replacement? Refixation.
She's 80-year-old.
80-year-old, yes.
You want to believe in God still? I mean, she should have the last operation of her life now.
Okay, so I did offer her a distal femoral replacement. She was not ready. They didn't hear about that and they were a bit confused. So we went ahead, we removed all the implants, and you can see that distal bone is still there. A lot of distal bone is there. So fixation is possible. And we did an antegrade nailing because this was a posteriorly stabilized knee, so we couldn't do a retrograde. And we could get a good fixation, distal fixation with 3 screws, and then we put a medial plate. And that was the result after about, I think, 10 months or so. So do you think the fracture is healing or healed? What do you say? That's distal to the fracture.
So because you're asking, there has to be a problem.
So medial, see, the medial continuity is there. Posteriorly, I can't say. Anteriorly also, it's a bit debatable.
Is this the final X-ray, Yatin?
That's 10 months.
No, is
No,
current.
No,
Are you
it's not
showing
current.
show more.
The picture, abhi baki hai.
No, I would have thought, would you, see, it is impossible to tell a 80-year-old person not to bear weight.
No, she's
Either,
bearing weight.
yeah, I know, but so she's going to bear weight. So would you consider bracing her while she is going through that phase?
You can't do that on an 80-year-old. No,
I mean,
bracing.
Some kind of a caliper or something you can give,
What he means is brace while walking.
Yeah, while walking.
Okay.
Because she's going to walk, she's going to fully weight bear.
So at 15 months, the plate broke. She had a bit of pain, and but she still continued to walk because the nail was holding. Nail will break. Anything you would do, or just let her walk?
Brace her now.
Brace her now.
Okay, so then another 3 months and
That also broke.
everything broke.
Is she a fat lady?
No, she's not a fat lady. You can see the thigh, it's not very fat.
Not a smoker either. So don't try to find an excuse.
So eventually I had to do this. So, but the lesson, what is the lesson learnt in this? And what has been recommended in the literature is, whatever is the fracture in periprosthetic area, always do nail and plate or dual plating. And make them walk right from day, post-op day. This is what is recommended in the literature, and there are a lot of, and there is no need for any bone grafting or anything like that. Yes, you can do bone grafting if you come across a, non-union or you're doing second time.
Yatin, in your first case, did you consider doing the bone grafting at the period of 6 weeks or so? That could have been one of the methods.
No, that's not recommended. What is recommended is either you fix it well on day 1, or if you are now faced with a non-union, and like I was faced with a broken plate, I did bone grafting at that time, but the bone was not very good. Her native bone also was not.
Did you consider giving magic drug?
No, that's all those things are.
We don't like magic drugs.
Excuse me, mechanical problem.
Okay,
Initially.
So
First time.
So do you have one more case quickly?
Excuse me,
because
sir,
we have
sir.
only 1 minute.
Can I make a comment?
Sir, one second.
For fixation, there are 2 clear
Your left
principles. Either your fixation has to be biological or it has to be rigid anatomical. You are mixing the 2 principles. You are exposed it too high and you have fixed it very rigidly, so your fixation has to fail. If you have done it, you should have bone grafted at the first time itself to add to the biology. You have fixed it rigidly and did a wide dissection, so it is bound to fail.
Mipo.
This is not a full incision. This is first 3 interfragmentary screws were there to fix the fracture and a neutralization plate which should be as long. In fact, the only mistake here in just this lateral plate is that a screw should have been passed into the head and neck to prevent any subtrochanteric fracture. But the other mistake was that it has to be a rigid fixation. For these patients, you cannot have a biological fixation and make them not walk. You have to have a rigid fixation, or more biological if you want, a nail and a plate.
So Yatin, we
Excuse me,
have a
sir.
sizable number of these fractures, and the only carry-home message we have carried out is, whenever you have a medial comminution, please use a dual plate.
Yes, that's right.
Sir-
So dual plate or a nail and plate.
So second
Nail
time
and
you have,
plate is a much better option.
sir, nail and plate second time, did you unitize the nail to the plate?
I didn't get it. What is it?
So for the nail and plate composite, you have to unitize the nail and plate. Did you unitize the nail and plate?
No.
So it is not a nail and plate composite.
It, well,
It is not.
It is not really a nail and plate. Nail and plate should be unitized, but then many times you are not able to put the screw right from the plate into the nail or nail into
Yatin,
the
thank you very much. You have incited so much discussion.